Hello everyone, welcome back again to this very first YouTube live session of Sermon Institute. I'm very sorry for the technical glitch that happened last time. So let us start with the most important questions of ENT. Right? Okay. Now remember, ENT is one of the most important subjects for you, and a lot of questions they are asked from ENT. And if you mark these questions correctly, you can get 100% marks in ENT. Okay. I'm Dr. Sarabjit Singh, your very own ENT faculty, and I'll be discussing all these questions. Let's straight away start with the first question. Okay. Just a minute. Let me adjust my screen so that the question is visible to you. Right. Okay. So let's start with the first question over here. One man had 30 decibel deafness in left ear with Weber's test showing more sound in the left ear and BC more on the left side and normal hearing on the right side. Right. So the question is, his test can be summarized as. Now I know that tuning fork tests, they are one of the most confusing topics for most of the students, and one of the questions is generally asked from the tuning fork topic. So let us have a quick revision of the tuning fork topic. Let's revise it and then we'll go ahead and solve the question. So tuning fork test, the first test that we have to remember is the Rinis test. Now the Rinis test is a comparison test. So remember, all tuning fork tests, they are comparison test starting with the Rinis test. So what do you do in Rinis test? You take a tuning fork, put it near the EAC, the sound goes through the air into the middle ear, then inner ear. It is known as air conduction. Now if you place the same tuning fork on the mastoid bone like this, okay, now the sound is going from the tuning fork directly to bone. Bone is taking to the inner ear. It is known as bone conduction. Right. Now remember, air conduction is always more than bone conduction. Why? Because middle ear amplifies the sound. Okay, so remember, air conduction is more than bone conduction. This is known as Rinis positive, and positive Rinis is a normal Rinis. It can also be seen in sensory neural hearing loss. Right. Okay, the next, when the air conduction is less than bone conduction, this is known as negative Rinis, seen in conductive hearing loss. So where do we have conductive hearing loss? Any disease of external ear or middle ear. Sensory neural, that means hearing loss is inner ear or beyond inner ear in the nerve pathway. Okay, so beyond inner ear in the nerve pathway, we have sensory neural hearing loss. Alright, now sometimes, however, we can have a false negative Rinis. Now this is seen in unilateral severe to profound sensory hearing loss, also known as dead ear. Okay, now quickly remember, there are three tuning forks that we can use for testing the of hearing: 256 Hz, 512 Hz, 1024 Hz. Okay, if all the three are positive, that means it's a normal Rinis, or it can be a sensory hearing loss, if all three are positive. If any one of them is negative, we will call it as conductive hearing loss. Any one. So if only 256 is negative, conductive hearing loss is 20 to 30 decibels. If 256 and 512, both of these are negative, as you can see over here, then the conductive hearing loss is 30 to 45 decibel. If all three are negative, then you can see conductive hearing loss is more than 45 decibels. So that was your first tuning fork test. Now the next tuning fork test is the Weber's test, and the Weber's test is the most sensitive tuning fork test. Now we teach you that first is the Rinis, second is the Weber's, but when you will go to solve your MCQ, remember, Weber's test has to be seen first. Okay, so this test has to be checked out first. Now, remember, what do you have to remember about Weber's? Normal Weber's is in the center. It goes away from sensorineural hearing loss and towards conductive hearing loss. Now, what does this statement means? This statement means that suppose an examiner tells you that a patient has Weber's going towards left. Okay, now if the examiner says that the Weber's is going towards left, it can have two possibilities, that the left is having conductive hearing loss, or we can even say that it is going away from right. Okay, suppose you are going from Delhi to Gurgaon, that means you can be going towards Gurgaon or you can be going away from Delhi. So same way, it is going towards left means it is having left conductive hearing loss, or maybe it is having, the patient is having right sensory neural hearing loss. Right? So any of these two possibilities are there. This is how we have to interpret the Weber's test. This is the most sensitive tuning fork test. Even with 5 decibel change in sound intensity, it will change. It will change the direction. Okay. Then a few more tuning fork tests that are sometimes asked. Number 1 is the absolute bone conduction test. Now we have seen the bone conduction. You put a tuning fork on the mastoid process and you do the bone conduction. In absolute, you take a tragus, you take your finger and press on the tragus and you close the EAC. Okay, that is absolute bone conduction test. It's a comparison test between the patient and the examiner. So if patient bone conduction is equal to examiner, it is normal. If patient bone conduction is less than examiner, that means patient is having sensory neural hearing loss. Okay, now if you fail to close the EAC by pressing the tragus, then this test will not be ABC, it will become Schwabach's test. And in Schwabach's test, patient bone conduction can sometimes be more than examiner, and that is known as conductive hearing loss. The remaining two results are there in Schwabach's, okay, but we have a third result when the patient bone conduction is more than examiner bone conduction, that means patient is having conductive hearing loss. Okay, examiner in both these tests is assumed to be normal. Okay, now the next test is the Giles test. So Giles test, remember, first thing, it is done for otosclerosis. So remember mnemonic GO, go otosclerosis, no change in intensity of sound on increase in pressure. Okay, and finally we have the Bing test. Now Bing test, again Bing negative for conductive hearing loss, no change in intensity. Right? Okay, so these are the tuning fork tests that you have to remember. Now let me take you back to the question that was asked. Okay, a man had 30 decibel deafness in the left ear. Okay, so this is mentioned to you. Okay, now with Weber showing sound, more sound in left ear, so that means Weber's is going towards left. Weber's is going towards left. All right, now Weber's is going toward left, that means left is having conductive hearing loss. Already it is told to you that the left side is having deafness. All right, and normal hearing on the right side. So right side, nothing is there. You don't have to even consider the right side. Right? Okay, now BC more on left side. Okay, so bone conduction is more than air conduction on left side. That again shows it is Rinis negative. Okay, and Rinis negative means conductive hearing loss. So both the things are same. Okay, so number 1, Weber's is going towards left. Okay, we have shown left is having conductive hearing loss. Second, Rinis, what we have seen is bone conduction is more than air conduction. That again shows it is having conductive hearing loss. Now let's look at the choices. His test can be summarized as, he has not asked the diagnosis from you. Weber test left lateralized, that is true. Okay, Rinis right positive, right side normal hearing is said, so normal hearing Rinis is positive. Bone conduction more than air conduction on left side, so this statement is true. Okay, this statement is true. Now let's look at the second one, Weber's test right lateralized, that is wrong, so let's leave it. Weber's test left lateralized, this part is true. Rinis right positive, air conduction more than bone conduction, that is wrong because This has been given in the question. This is wrong. Okay. Weber's left lateralized. Rinis equivocal. No, that is wrong. Okay. That is wrong. Rinis is not equivocal. Okay. BC more on right side. This is also wrong. So the answer to this question is choice A. Right? Okay. Let's go to the next question over here. Now, before we go to this question, now remember something about these tuning fork tests. Okay. Now, I have devised a 4-step formula to solve any type of tuning fork test. So, what is my 4-step formula? Okay. Now, this 4-step formula, the first step is to check the Webers. As I was telling you, this is the most important, most sensitive tuning fork test. So always check Weber's first. So let's take an example. In a question, the examiner says Weber's is going towards left. So it can be left conductive hearing loss. It can be right sensory neural hearing loss. Okay. So this is the first step. What we have done is we have just come down to 2 options in the questions. Out of the 4 options given, we have narrowed down to 2 options immediately. Now, next step is you have to check patient complaint side. Patient complaint side. Suppose the examiner says that the patient comes to you with right-sided decrease in hearing. So, right side is mentioned, answer is right sensory hearing loss. Left side is mentioned, then left conductive hearing loss. No need to see the Weber's. No need to see the Rinis test. Okay, Weber's we have seen first step, second step, patient complaint side, finish. Question is finished. In 5 seconds, question is finished. Now, let's go to third. Now, when will you go to third step? You will go to third step only when second step is not given. Okay, so when the second step is not given, when the patient complaint side is not given in your paper, in your question, then you will go to the third step. Third step, now you will see the Rinis. Okay, so Rinis, I told you, is a confusing test. Why? Because positive Rinis can be seen in normal, it can be seen in sensorineural. Negative Rinis can be seen in conductive hearing loss. It can also be false negative. Examiner will not tell you whether it is true negative or false negative. So it can be seen in severe sensorineural. Okay, so it's a confusing test. Now, how can we clear the confusion? So remember over here, negative Rinis is always seen in a diseased ear. It is never seen in a normal ear. Normal ear will always have positive Rinis. Okay, so now what we have to do, you have to see which side Rinis is negative. So if the examiner says right side Rinis is negative, that is the diseased ear, answer is right sensorineural. If the examiner says left side is Rinis negative, then it is left conductive hearing loss. Okay, so whichever side, don't have to think much. Whichever side in the question Rinis negative is mentioned, negative means bone conduction more than ear conduction. Okay, that is your disease side. Now, let's say the examiner says that bilateral Rinis positive. So you will reach fourth step only when second and third step are not there. Okay, so that means no side of the patient complaint is mentioned, no Rinis negative side is mentioned, both side Rinis has been told to us is positive. Now what do we do? So you see over here, positive Rinis is seen in normal and sensorineural. Positive Rinis cannot be conductive. Okay, so whichever side is having sensorineural, that is our answer. So in this, right side was having sensorineural, so that is our answer. Okay, now why with the positive Rinis it is sensorineural? Because you see in sensorineural Rinis remains positive. Air conduction remains more than bone conduction. Right? Okay, clear? Shall we go to the next question? So let's go over here to the next question. Let's look at some more tuning fork questions. Okay, so let's look at this question. A middle-aged woman presented with right-sided hearing loss. Rinis test shows a positive result on the left side and a negative result on the right side. So let's see over here. Weber's test shows lateralization to the left side. So this question has exactly come what I was trying to explain to you. So you see Weber's test showed lateralization to the left side. So we have to first see the Weber's test. It is going to the left side. Now patient complaint side is the second step. The patient complains with right-sided decrease in hearing. So we know the Weber's is going towards left. Left can be conductive, right can be sensorineural, and now we have our answer. It is right-sided sensorineural hearing loss. Okay, so we have clearly solved our answer over here, right? Okay, so this is how, we have to see. Now you can see the Rinis test also. We have already solved the question. Question is over. You have saved time by following the formula that I just gave you. But if you want to know further, Rinis test shows a positive result on the left side and negative result on the right side. Now, many students will say, sir, in sensorineural, Rinis is positive. But in the exam over here, the examiner is saying Rinis is negative on the right side. Okay, so the examiner is saying that the Rinis is negative on the right side, positive on the left side. So why this? So I just told you, in case of severe sensorineural hearing loss, severe or profound sensorineural hearing loss, Rinis is false negative. Okay, so this is actually a false negative Rinis that the examiner is not telling you, right? Okay, so that is our answer over here, answer number B over here, that is our answer. Let's go to the next question. Okay, so now we are going to collaborate this concept with some other thing. Okay, so how do we do that? A 38-year-old male patient presented with suspected diagnosis of suppurating labyrinthitis. Okay, so that means he's having inner ear disease, that there is a suppurating labyrinthitis. A positive Rinis test and a positive fistula test was recorded on the initial investigation. Okay, so Rinis test is positive, patient is having inner ear disease. Okay, maybe patient is normal or patient can be sensorineural, we don't know, but for us Weber's test has not been mentioned. So we can assume maybe there is an inner ear infection, so patient must be having sensorineural hearing loss. Now the patient refused treatment and returned to the emergency department after 2 weeks and complains of deafness in the affected ear. Okay, now on examination fistula test was observed to be negative. Okay, so now this is the change. The first change that has taken place over here is in the fistula test. So you see over here there was a positive fistula test earlier. So now let us remember the fistula test. So what is the fistula test? Whenever you press the tragus and move it in and out, so what happened? This change in pressure in the EAC, if there is a fistula in the inner ear, can go inside the inner ear, patient will have vertigo and nystagmus. That is known as positive fistula test or positive fistula sign. Okay, now after 2 weeks, the fistula test was observed to be negative. So patient has refused treatment. How can fistula test become negative on its own? So fistula test to be positive, what is required? A working inner ear. Now, without any treatment, fistula test has become negative. So that means it is a false negative fistula test. And when there is a false negative fistula test, that means there is a fistula, but the test result is negative. And this is seen if patient is having a dead ear, or if the patient fistula is covered by something like a cholestoma sac. No, that is not the case. Within 2 weeks it will not happen. So what has the case happened over here? Maybe because the patient refused treatment in acute infection, now the ear has become dead. Now this all has been deduced with the help of our fistula test. Okay, so fistula test From positive, it became negative. Right? Okay. So now, what is the most likely expected finding on repeating the Rinis test? So you see, now if we repeat the Rinis test over here, in a dead ear, Rinis test is false negative. Okay. So Rinis test is false negative in a dead ear. That is what we just discussed. Okay, so in a severe or profound sensory hearing loss or a dead ear, the Rinis test is false negative. All right, let's go to the next question. Now, a 38-year-old man presented with decreased hearing on the right side for last 2 years. Okay, now on testing with a 512 Hz tuning fork, the Rinis test is negative on the right side, positive on the left side. With Weber's test, the tone is perceived as louder in the left ear. Okay, so this is again a modification of the question. Just look at the question. What we have to see once again, Weber's is going towards left. Okay, so Weber's is going towards left. That means left can be sensory conductive or right can be sensory neural. Right? Okay, now what we have to see the patient complaint. Decreased hearing on the right side, right sensory neural. That is our answer. It is finished. Let's go to the next question. Okay, now a young man presents with an accident leading to loss of hearing in right ear. Okay, so there is a decrease in hearing in the right ear. On otoscopic examination, tympanic membrane was found to be intact. So tympanic membrane is intact. Pure tone audiometry shows an ear-bone gap of 55 decibels in the right side with normal cochlear reserve. Okay, so what does all this thing means over here in this question? Okay, now you see over here, I am looking at the chat also. If you have some doubts, you can just write it down to me over here in the chat. I'm looking at it, and whatever queries you have, you can just ask me there and I'll be happy to solve them. So let's make it a two-way interaction. Okay, so I can see you all guys being there. So let us solve all your queries. The idea of this session is that you can ask the questions also. All right, so now, which of the following will be the likely tympanometry finding? First thing over here, the patient had an accident. Now there is a loss of hearing in the right ear. Tympanic membrane is intact. That means external ear is normal. Okay, tympanic membrane is intact. Okay, now the problem can be in the middle ear or the inner ear. All right, now the PTA, pure tone audiometry shows an AB gap of 55 decibels. Okay, it shows an AB gap of 55 decibels. Now before I solve this question, let's look at the pure tone audiometry. Okay, so somebody wants me to say something again. So please, you have to tell me. I'll come back at the end of the session. I'll come back to whatever you want me to say again. Okay, now first thing is that the pure tone audiometry, the AB gap is 55 decibels. Let's look at the pure tone audiometry. Okay, then I'll come to this question. So these are the pure tone audiometry symbols that you have to remember. Now remember, right side is marked in red color, left is marked in blue color. Okay, now the air conduction on the right side is marked with a circle, left is marked with a cross. Now I have a very wonderful way of remembering them. As I have told you in my lectures, you must have watched those lectures. So right side and left side, I told you, left you can take for Congress and right you can take for BJP, and the left sides, left parties, we put them across. We don't want to vote for them. They are anti-nationals. Okay, so if there is some Congress supporter, please don't mind, it's just for remembering. So they are popularly known as anti-national, so we put a cross at them. Okay, and right side, they came with a promise that they will give us a lot of employment. So zero employment production. Okay, so we have put a 0 over here for the right people. Then if you see the air conduction masked, if you do a masking of the air conduction, so once again, left people, they were more interested in money. So they filled their boxes full of money and then they took them home. So they have a lot of boxes. Okay. Now the right-sided people, they are more interested in temples. So you see triangle. Triangle denotes the temple. Okay. So the temple, so they are making temples. A lot of temples over here. So right side is marked with temple when you do a masking. Alright. Now the bone conduction is marked with arrowheads pointing toward the side. So left, blue arrowheads pointing toward left side. Right-sided arrowheads, arrowheads pointing towards right side. Bone conduction, instead of the arrowheads, you can mark them with brackets. So these are the signs that you have to remember, and this is the final, the no response sign. For the air conduction unmasked, you can just point an arrow towards left side or right side. So this is a no response sign. Right. So now let's look at this. For a normal hearing, both air conduction and bone conduction curve, they will be near 0. Okay. So minus 10 to plus 25, that is the normal range. Okay. So they both will be near the 0 line. Remember, air conduction curve is a solid line, whereas bone conduction curve is a dotted line, or you may not even draw the line. Right. So this is your normal hearing. Then we have over here where the air conduction curve has gone down. The bone conduction curve is still near 0. This is known as AB gap. So there is a gap between the air curve and bone curve. This is known as AB gap, and that denotes the patient is having, that denotes the patient is having conductive hearing loss. So that means the problem is in the external ear or middle ear. Right? Okay. Now let's look over here in the third. Both air conduction and bone conduction curve, they have come down. Now this is the case of sensory neural hearing loss. And finally, when both of them have come down and there is also a gap between them, this is known as mixed hearing loss. Just to point out one more thing over here, you can see a dip over here at 4000 Hertz. Now this dip is known as Boiler's notch. It is seen in noise-induced hearing loss. Now remember, this dip, this notch has to be seen in bone conduction curve. Okay, you don't see any dip in air conduction curve. Notches, the dips have to be seen only in bone conduction curves. So this is a dip at 4000 Hertz. A similar dip at 2000 Hertz is seen in autosclerosis, and this is known as Carhart's notch. Remember, both the dips, both the notches have to be seen in bone conduction curve. Okay. Now before looking at the notch, first identify the type of hearing loss. Sensory neural hearing loss, first thing. Okay. So remember, noise induced hearing loss is a type of sensory hearing loss. Autosclerosis is a type of conductive hearing loss. So first identify the type of hearing loss and then go for the notch. Very important. Okay, now let's go to this question. So now what has happened in this question? Pure audiometry shows that there is a AB gap of 55 decibels in the right side with normal cochlear reserve. So bone conduction is normal cochlear reserve. Bone conduction is normal. There is a AB gap, conductive hearing loss of 55 decibels. So where do we have a conductive hearing loss of 55 decibel? In case of ossicular discontinuity. So as we have determined, you can see the tympanic membrane. Tympanic membrane looks normal. That means EAC is also normal. Tympanic membrane is also normal. Okay. So most likely there is ossicular discontinuity. And what kind of tympanometry we will have in ossicular discontinuity? We have a AD type of tympanogram. Okay. Let's revise over here the tympanometry. So remember, first thing, impedance audiometry combines tympanometry and stapedial reflex test. So first thing, remember, impedance audiometry consists of two tests. Right now we are talking about tympanometry over here. So tympanometry, the normal curve is the A type curve. This is a normal curve. Okay, a small curve is known as AS curve. S for sclerosis, autosclerosis. So this is seen in autosclerosis, tympanosclerosis. Okay, so autosclerosis or tympanosclerosis. Over here, the stiffness has increased. So this is because of increase in stiffness. In otosclerosis, stapes foot plate is fixed. Tympanosclerosis, there is chalky white deposits on the tympanic membrane, so tympanic membrane becomes thick and stiff. Okay, next is the AD curve. So D for discontinuity. D for discontinuity, ossicular discontinuity. You can see the curve is also discontinuous. D for decrease in stiffness. This is the type of curve you will get in ossicular discontinuity. Okay, next we have the B curve. The B curve, it's a flat curve, and this flat curve is seen in fluid in the tympanic membrane. Okay, so this is seen in the fluid in the tympanic cavity, middle ear. Okay, so such as serous otitis media. Right, and then we have over here the C curve. This is seen in retraction, tympanic membrane retraction. Okay, so these are different types of curve that we are able to see. So the answer was AD. Okay, next question, let's come over here. A 35-year-old female patient presents with hearing loss with improvement in hearing in noisy environment. What do we call it? We call it as paracusis Willisii. Okay, when patient hears better in a noisy environment, it is known as paracusis Willisii. So remember, very important keyword, paracusis Willisii. Where have I taught you this? This I have taught you in otosclerosis. Okay, just look at the keyword, the answer will become easy for you. Alright, paracusis Willisii, hearing better in a noisy environment. Otosclerosis, which type of females? So it is, which type of patients? So female patients, 20 to 30 years generally. Over here 35 year is mentioned. Okay, so it can be, right? Then what else? Pregnancy. Incidence is more during pregnancy. Autosomal dominant disease. Okay, so family history is also there. Now let's look at the question. Further question. On examination, Rinis is negative. Now we have identified a few things, but we have not fixed. We look at the complete question before finalizing our answer. Okay, so don't get fixed by just looking at one point. Read the entire question. Very important tip in your exam. On examination, Rinis is negative, Weber's is centralized. So Rinis is negative, all right, and Weber's is centralized. They have not told you which side Rinis is negative. Remember, otosclerosis is generally a bilateral disease. So maybe the examiner want to say right side is negative, left side both are negative. We don't know. Following is the audiometry report. Now audiometry only blue color is there. So only left side is mentioned. So we will take left side Rinis to be negative. We are not concerned about right side. Okay. So only left side is mentioned to us. We'll only see the left side. Now what do we see in this? We see that there is a AB gap. It's a conductive hearing loss. There is a AB gap. What else do you see? You see there is a dip. There is a notch in bone conduction. Okay, so look over here. There is a dip. There is a notch in bone conduction at 2000 hertz. Okay, so at 2000 hertz. So this means it is a case of otosclerosis. As I was telling you, otosclerosis, this is your Kerhart's notch. Okay, right? So Meniere's disease, perilimb fistula, stapedial otosclerosis. Stapes is fixed. All right, so that is our answer in this question, right? Okay, let's go to the next question. So Dr. Thakur is saying NPC also B type. Yes, in NPC there is serous otitis media. Okay, so remember the Trotter's triad in NPC, there is serous otitis media, there is collection of fluid, and therefore the tympanometry will show B type curve, right? Okay, now let's go to the next question. 7 years old child is complaining of hearing loss and sense of fullness in the ear. Okay, so you see over here 7-year-old child complaining of hearing loss and sense of fullness. The tympanometry shows type B curve. Type B curve means there is fluid. As I was just telling you, fluid means it is a case of serous otitis media. Right? Okay, it's a case of serous otitis media. Right? So that is the answer over here. Now remember, sometimes the question may go further. You see 7 years old child. So remember, 5 to 7 years we have adenoid hypertrophy. Okay, and this adenoid hypertrophy leads to bilateral serous otitis media. So in 7-year-old child, the cause of type B curve in the ear is actually adenoid hypertrophy. All right, and we may have to do adenoidectomy to get to give relief to the patient. Right? Okay, so remember, this is very important. You have to correlate. Sometime treatment is asked, the patient is told that mouth breathing is there, mouth remains always open, adenoid faces like features are there, so something like that is mentioned. So in a 7-year-old child, okay, 7-year-old child, remember 5 to 7 year adenoid hypertrophy is seen, and if that is the case over here, so you should always remember that the cause can be adenoid hypertrophy. Right, let's go to the next question over here. Post head injury, the patient had conductive deafness. Right, and on examination tympanic membrane was normal. So there is an injury, conductive hearing loss, tympanic membrane is normal and mobile. Okay, so likely diagnosis is, see, this is very important. So suppose tympanic membrane was normal, but there is fluid, there is blood behind the tympanic membrane. Okay, that we will call as hemotympanum. But over here it is mentioned that the tympanic membrane is mobile. If there is blood, it will not let the tympanic membrane move. Okay, so what is the cause over here? Now the cause over here is that the ossicular chain is broken. All right, the ossicular chain is broken, therefore the tympanic membrane rather becomes hypermobile. It is more mobile than usual. Right, so distortion of the ossicular chain, that is the answer. Yes, Dr. Deepu, I will be keeping this video until the exam and later also. You can access the video later on also. Okay, next question over here. A lady has bilateral hearing loss since 4 years, which worsened during pregnancy. So you see over here, as I was telling you, otosclerosis. Look over here, lady, otosclerosis. Okay, why I am saying otosclerosis? Bilateral hearing loss for 4 years, which worsened during pregnancy. So identify these keywords. So otosclerosis, what type of impedance audiometry curve you have? You have AS type of curve. Okay, you have AS type of curve over here. Let's look at this question. Right, so let's look at this question. A young man with history of ear infection presents with a smooth erythematous swelling on the mastoid process as shown below. What is the most likely diagnosis? So we have a photograph over here and you can see that there is a erythematous swelling behind the pinna, right, on the mastoid process. So now what is the most likely diagnosis? So let's look at the signs. Let's look over here at the signs over the mastoid. Now the first sign over here is ironed out mastoid. Okay, so ironed out mastoid, red, hot, smooth mastoid. Now this is seen in case of acute mastoiditis. That is in case of acute mastoiditis. Now the next is Battle sign. There is ecchymosis, there is hematoma. Okay, so you can see there is hematoma over the mastoid process. Okay, now as I was telling you, suppose there is an injury to the middle cranial fossa. There is an injury to the middle cranial fossa, there is a fracture of the middle cranial fossa, right, and there is hematoma over the mastoid. This is known as Battle sign, right. Okay, and the next, Gressinger sign. Gressinger sign is edema, pitting edema over the mastoid. This is seen in sigmoid sinus thrombosis. It is actually because of thrombosis of the MS3 vein. Okay, that drains into the sigmoid sinus. So if the sigmoid sinus is thrombosed, the MS3 vein also undergoes thrombosis automatically. So there is pitting edema over the mastoid process. Right, so these are the three different signs. Now the first sign that was asked from us over here was the first sign. There is smooth erythematous swelling. So I told you red, hot, smooth. So erythematous means red, smooth. Okay, so answer over here is acute mastoiditis. Right, so the answer is acute mastoiditis. Right, okay, let's go to the next question. A patient presented to ENT OPD with complaints of vertigo and nausea in the morning on change in position of the head. What is your diagnosis? So you see over here, complaints of vertigo and nausea on change in position of the head. So whenever there is a change in position of the head is mentioned, it's a case of positional vertigo. Okay, and you know that gives us the name BPPV. There's only one thing that is mentioned, one vertigo mentioned for you, which happens with change in position of the head. Positional vertigo, benign, paroxysmal, positional vertigo. So remember, vertigo, especially BPPV, is a very favorite topic of the examiner. Every year, every session, they will ask at least one question from here. So BPPV, very important question over here, right? Okay. So let's quickly revise BPPV. This is the most common cause of vertigo. Why the vertigo is happening? Because of displacement of this otoconia to the posterior semicircular canal. Posterior semicircular canal, this is the most common location for the otoconia. Now, this vertigo is a peripheral vertigo. It will happen in change in head position. This comes in paroxysm, sudden burst. As soon as the patient moves the head, there is a paroxysm, there is a burst of vertigo, and this vertigo lasts for seconds to a few minutes, right? This condition is also known as otolithiasis, and these otoconia which have not displaced, now they are also known as otolith. Okay, now next question which is asked from you is, how do we diagnose this condition? So we diagnose it with the help of Dix-Hallpike maneuver. Alright, so remember Dix-Hallpike maneuver, turn the patient head by 45 degrees to the side you want to test, and then turn the patient from sitting to supine position. This is known as Dix-Hallpike maneuver. Okay, and what do you have? You have a upbeating, that is agiotropic, and torsional nystagmus. Okay, why torsional? It's a posterior semicircular canal problem because posterior canal communicates with superior semicircular canal also by crus commune. So it's a torsional nystagmus. We never see pure vertical nystagmus in peripheral disorders. Pure vertical nystagmus are central nystagmus. Okay, so remember over here, BPPV nystagmus is upbeating, that means against the gravity, agiotropic, torsional nystagmus. Right? How do we treat this condition? The best maneuver to treat is Apley's maneuver. So remember, Apley's maneuver, Dix-Hallpike maneuver, favorite of the examiners. They are asked lot of times. So BPPV, most common cause of vertigo, diagnosis by Dix-Hallpike, treatment by Apley's maneuver. So what do we do in Apley's? You reposition the otoconia or the otolith back to the utricle and saccule from where they came. Right? Okay, let's go to the next question over here. A mother brought her 6-year-old child to ENT OPD with complaints of recurrent crying and hearing loss. On otoscopic examination, following findings are seen. Identify the diagnosis. Now, this is a spot diagnosis. You just have to look at the photograph and the answer is clear. Remember, picture-based questions, image-based questions, IBQs. Now, these are very simple to solve if you know the image. So, if you have done the images, they are very easy to solve. So, one day is remaining for your exam, and I'll ask you that you revise the most important topics, what you think are volatile. Tomorrow you revise them and you go through as many images as you can. Okay, so if you are not able to study anything, you are filled with anxiety, okay, just relax, open up the images, open up the snapshots and just revise them. Just go through them, just have a look at them, nothing else. Don't try to remember them, just have a look at them. They will come to you in the exam. Lot of IBQs are expected in this time exam. All right, so look over here. What do you see? You see in the middle ear there are a lot of air bubbles. Now where are the bubbles? Bubbles are formed inside water. Bubbles are formed inside water. Okay, now that means there is water inside the middle ear, behind the tympanic membrane. So where is the water? Water is in serous otitis media. But I don't see a term serous otitis media. Okay, I see a term otitis media with effusion. That is the other name for serous otitis media. Okay, this is the other name for serous otitis media. So 6-year-old child, see, remember over here, 6-year-old child, I was telling you 5 to 7 year adenoid hypertrophy is there. The child is likely to have serous otitis media. Recurrent crying and hearing loss. So in between, patient may be having pain, and there is of course hearing loss. On otoscopic examination, we have over here bubble. So that is a case of serous otitis media, also known as otitis media with effusion. So serous otitis media, secretory otitis media, mucoid otitis media, non-suppurative otitis media with effusion, glue ear. These are all different names for your pathology over here. And you can sometimes see a middle ear completely full of fluid. You can see a air fluid level over here. You can see the air fluid level, and sometimes you can see a lot of air bubbles, and sometimes again over here you can see the air fluid levels. Sometimes you can even see a blue tympanic membrane. Right? Okay, so remember, blue tympanic membrane you can see in serous otitis media. You can also see in hemotympanum, blood in the middle ear. You can also see in a cholesterol granuloma. Right? Okay, so the answer, remember, blue tympanic membrane can sometimes be also seen in serous otitis media. Alright, let's go to the next question over here. A patient after being slapped 3 days ago presents with decrease in hearing and no pain. So 3 days ago patient was slapped. Following is the examination finding of tympanic membrane. We can see that there is a hole. Okay, we can see that there is a hole in the tympanic membrane. What is the next line of management? Now, there is a history of slap, there is a history of trauma. Now, how does a traumatic tympanic membrane look like? Look, let's see over here. A traumatic tympanic membrane immediately after trauma. It is rough. It is irregular in shape. Okay, margins are rough, or you can say ragged margins. Okay, you can see that there is blood clots around the perforation. Right? So you can see rough, ragged margins, irregular tympanic membrane perforation. You can see some blood clots around the tympanic membrane. Right? So these are the examples of traumatic tympanic membrane perforation. Right? Okay, now let's look in this photograph. Now the history of this question is that the patient was slapped 3 days ago. Now what will happen in 3 days? In 3 days, obviously the tympanic membrane will start healing. Okay, so maybe that this perforation, it has started healing. We don't know. Okay, so what is the next line of management? Patient has come to you after 3 days and you see that there is a perforation, there is a clear-cut history of slap, and after that there is a decrease in hearing. So what will you do? You will wait. Okay, you will let this perforation heal on its own. If the perforation does not heal, then only you will do something. Okay, why? Because more than 95% cases, these perforation, they will heal on their own. You don't have to do anything. Right? So yes, I know the margins over here are not ragged. Okay, so many students were confused. The margins over here are not ragged. You are not able to see the blood clots. But look at the history. 3 days have passed. So in 3 days, the perforation will start healing on its own. Okay, the roughness, the raggedness will go down. The blood clots, maybe there are only few blood clots. They may be seen, they may not be seen after 3 days. So what you have to do is, you have to wait and watch. You have to give benefit of doubt to the patient. We will not go to the surgery immediately. Okay, there is no discharge, there is no pus, there is no infection, so no need of any antibiotic. Right? Okay, there is no need of any antibiotic. Right. Next question is about tuberculous otitis media of the middle ear has all of the following excepts: multiple perforations, pale granulations, ATT, anti-tubercular should be started, painful otorrhea. Okay, so let's see what do we have in tuberculosis of the middle ear. Now tuberculosis is a chronic painless foul smelling otorrhea. So first point over here, painless otorrhea. Okay, so you have your answer over here. This is the wrong answer. Okay, this is the wrong answer. Or in tuberculosis, the otorrhea, the ear discharge is a painless otorrhea. Right? Okay, so first thing, chronic painless foul smelling otorrhea. There are multiple perforation, we call it a sieve-like tympanic membrane. There are pale granulations in the middle ear. Patient is having severe hearing loss. Okay, if it is a conductive hearing loss, it is out of proportion to the symptoms of the patient, to the complaint of the patient. And sensory hearing loss may be there, that means the inner ear is involved in tuberculosis. Patient can also have facial nerve palsy. So this is a sieve-like tympanic membrane. Alright, and all these perforation in the later stage, they can combine, they can coalesce, and they can form a big perforation, and you can see pale granulations in the middle ear now. Okay, so patient has these pale granulations, and then patient will also have painful otorrhea. Right, let's go to the next question. A 14-year male patient presents with recurrent spontaneous bleeding from left side. Now, remember, teenage group, male patient, and history of bleeding. Whenever you have these three things, your first diagnosis should be JNA, juvenile nasopharyngeal angiofibroma. Three things. Okay, let's see the question now. Ahead, on examination, pink mass covered with mucosa is found in the nasopharynx. So juvenile nasopharyngeal angiofibroma, okay, there is a mass in the nasopharynx. It has a false pseudo capsule. Okay, so the answer over here is most likely to be JNA. Now the question is, which of the following is not to be done in this scenario? Now you see, if you are suspecting JNA, what will you do? You will try to diagnose it with the help of CECT, contrast enhanced CT scan. Okay, and if you diagnose it, you can do surgery also. Surgery nowadays preferred is endoscopic surgery. Before surgery, many surgeons like to decrease the blood supply so they can go for pre-surgery embolization of artery. Now remember, in case of JNA, you never do biopsy. Okay, so this is your answer over here. You will not do biopsy of JNA. JNA biopsy is absolutely contraindicated. Why? It is full of blood vessels, so there will be a lot of bleeding. It has multiple blood supplies, and these blood vessels do not have the contractile tunica media. So it will keep on bleeding, all right? So, and there is a false capsule, so lot of bleeding will be there. No way to control the bleeding. So JNA biopsy is absolutely contraindicated. This is not to be done. Right? So remember, JNA, this is the most common benign tumor of the nasopharynx. Site of origin is near the sphenopalatine foramen and the pterygoid base. Alright, so that is your sphenopalatine foramen over here. So between this sphenopalatine foramen and pterygoid base, this is the place. This is your pterygoid plate. Okay, this is the sphenoid sinus, so sphenoid bone, you can see the sphenoid sinus, so that's the pterygoid plate. This over here, as I marked earlier, this is your sphenopalatine foramen, so between the sphenopalatine foramen and the pterygoid base, so this place that I am now marking, this is the most likely site of origin of the JNA, right? Okay, characteristics of JNA, it's a testosterone dependent tumor, so T is seen only in adolescent teenage group males. There is no true capsule, multiple blood supplies, and no tunica media. So bleeding is the most important characteristics. What kind of bleeding? Excessive recurrent bleeding. Right? Okay, patient presents with profuse recurrent epistaxis. Patient may also have nasal obstruction. It can also go to the pterygomaxillary tunnel into the cheek. Patient can have cheek swelling, and on examination we can see a red colored polypodal mass in the nose and nasopharynx. Right? Okay, sometimes it can go into the orbital cavity. This is proptosis. The eyeball is coming out and the distance between the two eye, they have increased. This is known as telecanthus. Together it is known as frog face deformity. Right? Okay. So next question. Angiofibroma bleeds profusely because it has multiple blood supplies. As I told you, most common blood supply is sphenopalatine artery, SPA. Okay, but wherever it grows, it takes the blood supply from that place also. So it has multiple blood supplies. Next, it lacks a capsule. As I just told you, it lacks a capsule, no true capsule. Okay, vessels in it lack a contractile component, that is tunica media is absent. Okay, so all three are correct. Answer is all of the above. Right? Okay, so next question over here. A 18-year-old male presented with chief complaint of recurrent epistaxis with nasal blockage. So once again, over here you see 18, teenage group, male, recurrent epistaxis. So what is our diagnosis? Our basic diagnosis is JNA. That's our provisional diagnosis with the first line. With nasal blockage, of course, JNA will cause nasal blockage. On examination, a polypoidal mass is seen going from nose to nasopharynx. Right? Okay, completely occupying the posterior choana as seen in the following image. So you can see in the image, there is a reddish polypoidal mass. Okay, fleshy, looking like full of blood vessels. So it gives more confidence to our diagnosis of JNA. Now, how will you confirm your diagnosis? You will confirm it with the help of CECT. Okay, so you do a CECT, enhanced uptake of contrast. So whenever there is a vascular mass, it will take more contrast. So it will be an enhanced uptake of contrast is seen. So answer is JNA, nasopharyngeal angiofibroma, juvenile nasopharyngeal angiofibroma. Let's go to this question. An unimmunized 2-year-old girl presents with high-grade fever and sore throat. On examination, she is toxic in appearance and having bilateral cervical lymphnopathy. Throat examination showed below findings. What is the most likely diagnosis? Now, what do you see in the photograph over here? In this photograph, you can see that there is a membrane. Where? Over the tonsils. So this question is a question of membrane over tonsils. Okay, now let's look at the DDs of membrane over tonsils. Now when we go to the DDs of membrane over tonsils, now first acute membranous tonsillitis. So acute membranous tonsillitis, you see there is a follicular tonsillitis and all these, they coalesce, all these follicles, the pus formed over here coalesce, and this leads to formation of membrane over the tonsils. So pyogenic infection. Okay, pyogenic infection, streptococcal infection, that can lead to a membrane over the tonsils. What else can be there? Diphtheria. Causative agent, Corynebacterium diphtheriae. What happens in this? There is formation of a pseudomembrane. Okay, so there is formation of a pseudomembrane. That is the most important over here. Okay, why do we call it a pseudomembrane? It bleeds on peeling. Now, what is most important to us is the history of diphtheria. Remember, we have a DPT, diphtheria, pertussis, tetanus vaccine. Okay, DPT, diphtheria, pertussis, tetanus vaccine. So, remember, a patient has to be unimmunized. So, any question that mentions a immunization history that the patient is unimmunized, that means the examiner is pointing towards diphtheria. Right? So patient will be a 2, 3-year, 4-year child presenting with, presenting with fever, bilateral cervical lymphnopathy. What do we call it? We call it as bull neck. Characteristic, bull neck, bilateral tonsillar hypertrophy. Now diphtheria, toxin is released in the blood. So patient will have a toxic look. Okay, toxin, poison is released. So even if you give a small amount of poison, what will happen to the patient? Patient looks very sick. So diphtheria releases toxin, diphtheria toxin. Okay, so patient has a toxic, very sick looking appearance. right? Okay, and how do you confirm it? You take a throat swab, you do a Albert staining. Okay, you have a Chinese letter appearance. That is because of the metachromatic granules, you have a Chinese letter appearance, right? So the question was clear over here. 2 years old unimmunized girl presents with high grade fever and sore throat. On examination, patient is toxic in appearance. Very important, toxic, and having bilateral cervical lymphnopathy. Throat examination, you can see the pseudomembrane. So most likely diagnosis is diphtheria over here. Okay, let's look at the other membrane DDs over here. So infectious mononucleosis, 20 to 30 years. Okay, 20 to 30 years. Caustivision, Epstein-Barr virus, EBV, 20-30 years. Again, there is fever. Okay, there is bilateral cervical lymphnopathy. Sometimes in viral infection, you can see palatal petechiae. So palatal petechiae are seen in viral infection. So Epstein-Barr virus, EBV, there is a viral infection. Okay, sometimes you can have a membrane over the tonsils. So once again, there is membrane, but the age group is different over here. Okay, how do you confirm now? You do a Paul Bunner test or a monospot test or a heterophile antibody test. So these are all microbiology tests that are done to confirm Epstein-Barr viruses. You can also do a CBC. If you do a CBC, complete blood counts, you will see that there is increase in leukocytes. So leukocytosis and lymphocytosis, increase in lymphocytes. Peripheral smear, 10% cells are atypical cells. If you do a peripheral smears, 10% cells are atypical cells, right? Okay, next is candidiasis. Candidiasis seen in immunocompromised patient. You can also see in patients on steroids, steroid inhalation, like asthma, COPD patient. So candidiasis, also known as oral thrush. So history will be there of a COPD patient or a asthma patient on steroid or immunocompromised patient. Next, we have Vincent's angina, trench mouth. So it is also known as acute necrotizing gingivitis, and this is caused by Borrelia vincenti and Fusobacterium nucleatum. Okay, so mainly Borrelia vincenti, by that the name came as Vincent's angina. Okay, along with the anaerobe is Fusobacterium nucleatum. Again, there is formation of a membrane, it's a pseudomembrane, but now the gums, the gingivas, they have an acute necrotizing condition along with it, right? All right, now remember Vincent's angina, it is related to a membrane over tonsil. This question is sometimes asked, okay, which of the following does not form a membrane over the tonsil? Answer to that question is Ludwig's angina. Ludwig's angina has no relation to tonsils. Ludwig's angina is a cellulitis of the submandibular space. It's an infection, soft tissue infection of the submandibular space. It has nothing to do with tonsils. Tonsils, there is Vincent's angina, right? So agranulocytosis, again in these patients on chemotherapy, leukemia patients, so there is formation of these patches. So they lead to look like that there is a membrane. These patches can also be seen on the tonsils like we are seeing over here on the palate, right? Okay, and then sometimes we can have aphthous ulcers. Aphthous ulcer also known as canker sores, very painful ulcers, and they can also be on the tonsils and they can look like membrane over the tonsil, right? Let's come to the next question. A 15-year-old boy presented with history of fever since last 2 days. He is unable to swallow food and having muffled voice. Okay, on examination it is noted that the right side tonsil is shifted to midline. What is the diagnosis? Quinsy, acute tonsillitis, parapharyngeal abscess, acute retropharyngeal abscess. Now this is one of the favorite question of the examiner. It was repeated 4 or 5 times continuously in the FMG exam from 2018 till 2020. 5 times continuously this question was again and again asked from the students. Simultaneously this question was also asked in the NEET exam and the AIMS exam. Now, why this question has become such a favorite of the examiner? Because there is a trick over here. If you are able to solve that trick, you are able to solve this question. So let's understand that. Let's look at this diagram. So what is this diagram? If you remember this diagram, you'll remember all the related abscess question of the head and neck region, and they definitely come in the exam. Right? Okay. So we have the oral cavity. We have the oropharynx. On both the sides of the oropharynx, we have the palatine tonsils. This is the cervical vertebra. So basically, this is a axial cross section. Right? Okay. Now what we can see over here? We can see over here the cervical vertebra, the oral cavity, the oropharynx. You can see the palatine tonsils. Now, what else can you see? You can see the palatine tonsils. On the wall, the bed of the tonsils is formed by the superior constrictor muscle. Covering the superior constrictor muscle, and between the superior constrictor and the palatine tonsil, the fibrous capsule of palatine tonsils, in between them we have a space over here. This space is known as peritonsillar space. An infection of this space leads to peritonsillar abscess, also known as quinsy. Okay, now what will happen if there is a quinsy? If there is a quinsy, patient will have dysphagia, patient will have pain in throat, okay, patient will have muffled voice, right? Now, remember, patient will have dysphagia, patient will have fever, dysphagia, as mentioned in the exam, everything that was mentioned in the question. Patient will also have muffled voice. Okay, what else the patient will have? Patient will have on examination hypertrophy of the tonsils. Tonsils are red, congested, reaching midline on their own. Okay, red, congested, reaching midline. Right? The word over here is reaching midline. When you reach midline, you reach on your own. Right? Okay, now let's go ahead. Covering this superior constrictor muscle, we have over here the buccopharyngeal fascia. So this fascia over here, that's your buccopharyngeal fascia. Right? Okay, then we can see covering the vertebra, just anterior to the vertebra, we have the prevertebral fascia. So between the cervical vertebra and the prevertebral fascia, we have a space over here. This space is known as prevertebral space. Right? So this space over here, this space is known as prevertebral space. Now, between the prevertebral fascia, just anterior to that, you can see that there is a alar fascia. Okay. Now, between this alar fascia and the prevertebral fascia, we have a space. This space is known as danger space. Now, remember, if there is a abscess of the prevertebral space, there is a prevertebral space abscess, this abscess will be like this. Okay, so that means where is the abscess now? The abscess is now in the posterior pharyngeal wall. Okay, this abscess is now in the posterior pharyngeal wall, number one. Number two, this abscess is right in the center. It is pushing the posterior pharyngeal wall from the center. All right, okay, now let's look over here, the buccopharyngeal fascia as I was mentioning. So between the buccopharyngeal fascia and the alar fascia, there is a space. This space is known as retropharyngeal space. Now look carefully. The buccopharyngeal fascia condenses in the midline. So as you can see over here, it is condensing over here in the midline. So therefore, there is not one retropharyngeal space, rather there are two retropharyngeal spaces. One on right side and one on left side. Okay, be careful about it, be clear about it. There are two retropharyngeal spaces because the buccopharyngeal fascia condenses in the midline. So therefore, a retropharyngeal space abscess will be only on one side. Okay, so it will be pushing the posterior pharyngeal wall, but only on one side. So that's the difference between a prevertebral space abscess and a retropharyngeal space abscess. That is how you have to remember that on examination, buccopharyngeal fascia condenses the midline. So retropharyngeal space will be on one side of posterior pharyngeal wall. Okay. Prevertebral space abscess will again be on the posterior pharyngeal wall, but in the center. Right? Okay. Next, let's come to the side. Now, when we come to the side, we have already discussed the quinsy. Okay. Now, beyond this, we can see the parapharyngeal space. Okay, so we can see over here this parotid gland, we can see the ramus of the mandible, we can see over here the masseter lateral to the mandible, and we can see the medial pterygoid. Okay, and this space over here, this is known as parapharyngeal space. Now if there is a parapharyngeal space abscess, okay, it will also come like this. Okay, it will also come like this. Now what will happen? It will push everything here. Okay, so you can see that the tonsils will now be pushed to the midline, or maybe even beyond midline. So now that is the trick in this question. If the examiner says tonsils are, on examinations tonsils are red, they are congested. Okay, tonsils are red, tonsils are congested, they are reaching midline, they are hypertrophied. Any of these words is used, that means something is there in the tonsil itself. That means patient is having quinsy. If the examiner simply says tonsil is pushed to midline, so there is a swelling in the lateral wall, it is pushing the tonsil to midline. So that means when you are pushed, that means something is pushing you from behind, then the answer has to be parapharyngeal space abscess. Right? Okay, so I hope that is how you are able to solve this question. Now also remember that there is a styloid process along with this muscles and ligaments around it. So we call a styloid apparatus that divides the parapharyngeal space into anterior compartment and posterior compartment. Anterior compartment abscess leads to trismus. Okay, anterior compartment abscess leads to trismus because of involvement of medial pterygoid muscle. Okay, which muscle is involved? Medial pterygoid muscle is involved. Right? Okay, let's go to this question. Ludwig's angina. So this question came, I told you just some time back. Ludwig's angina has nothing to do with the tonsils. This is a rapidly spreading cellulitis of submandibular space. Okay, it's a rapidly spreading cellulitis of the submandibular space. Right. Okay, let's come to this question. Again, important question. 2-year-old child presents with complaints of fever, barking cough and stridor for 2 days. What is the most likely diagnosis? Now the key word mentioned over here is barking cough. The examiner mentioned barking coughs, gives away the entire question group. Acute laryngotracheobronchitis, LTB. Okay, so LTB, the feature is barking cough, seen in 3 months to 3 years old child. Infection by virus. Okay, so it's a viral infection, LTB, short duration, right? And the patient has fever, patient may have stridor, patient has difficulty in breathing, dyspnea, patient has barking cough, right? Barking cough, very important, right? Now let's look at this question. 2-year-old child presents with following X-ray findings. So what you have to do, it's an image-based question. You just have to look at the image. Now what do you see in the image? In the image, you can see this is a AP view, and what do you see over here? You can see that the airway is getting narrowed. Okay, so what you can see, you can trace the airway over here, and it is becoming like this. This is known as steeple sign. Okay, this is known as steeple sign, and the steeple sign is seen in, once again, acute laryngotracheobronchitis. So that is our answer in this question. Right? Okay, let's go to the next question over here. A 4-year-old child presented with respiratory distress, fever and inspiratory stridor. X-ray, soft tissue neck, lateral view is showing thumb sign. Okay, so thumb sign, yes, my dear friends, thumb sign, where do we see thumb sign? Thumb sign is seen in acute epiglottitis. Okay, acute epiglottitis, you see thumb sign. So thumb sign is mentioned to you, answer is mentioned to you, acute epiglottitis. What is the most likely causative organism? So once again, please remember this thing. As per the new Scott Brown, once again, the most likely diagnosis, the most likely causative organism is Haemophilus influenzae Hib. Okay, don't get confused. Despite vaccination, despite everything, most common causative organism is Haemophilus influenzae type B. Right? Okay. Clear? Streptococcus. Yes, Dr. Ritesh, Streptococcus is not the answer. Now remember, I am again telling you, don't make this mistake in the exam. You see, only a few developed countries where Hib vaccination was introduced, Streptococcus pneumoniae became the most common organism. But in India, Hib is not in universal vaccination program, and worldwide also. So India as well as worldwide, Hib is still the most common causative organism. Right? So please clear this fundamental. This question was asked last year also in the exam. Many students committed the mistake. Streptococcus pneumoniae is not the most common organism. Most common organism is still Hib. The latest edition of Scott Brown has once again said, despite vaccination, Hib is the most common causative organism. Right? Okay. Next, look over here. What do you see over here? You see over here, this is a normal X-ray where you can see that the epiglottis is thin leaf-like epiglottis, and over here you can see that this epiglottis is swollen like a thumb. Right? Okay. So this is a thumb sign and it is seen in acute epiglottitis. Right? Okay. So yes, Dr. Hiremat, many institutes, many people are saying that it is Streptococcus, and that is why I have kept this question. Okay, that is why I have kept this question for you, because Haemophilus influenzae, as per the latest edition of Scott Brown, is still the most common causative organism. Right? Okay, so these were the questions that I wanted to discuss with you. These are the most important questions, and these are the topics, these questions which are repeatedly being asked in the exam. So I wish you best of luck, and I hope that you are able to solve all these questions. All right. So best of luck. Give your best. Just relax, chill. No need to worry. You have prepared your best. You have done your best. So no need to worry. Just relax and give the exam. As far as tomorrow is concerned, try to revise. Be calm. If you are traveling, go to your center, take adequate rest so that you are fresh and you are able to give your best day after tomorrow in the exam. Right? So thank you and best of luck for your exam. All right? And I'll try to upload the PDF also for you guys. All right? Okay. Thank you and best of luck.